Hi, I'm Dr. Tejaswini, Administrator, Shankara Academy of Vision. Today we have Dr. Madhukumar, Consultant Vitreoretina Surgeon from Shankara Eye Hospital, Guntur. Dr. Madhukumar is associated with Shankara from the past 13 years. He is heading the Department of Vitreoretina in Shankara Eye Hospital, Guntur. He performed more than 12,000 surgeries in Vitreoretina department. He has a PG teaching experience of over 12 years. We welcome you, sir. Thanks for doing this lecture on myopic retinoschisis. Over to you, sir.
Thank you, Dr. Tejaswini. So I'll start sharing my. It says host disabled participate screen sharing. You have to allow me to share the screen. So can you see my slides?
Yes, sir. Please continue.
Okay. So hello, everybody, and I welcome you all for this Educate for Eye Care series on the eve of World Sight Day. So today I'll be speaking about the myopia and its associated disorders. So as we all know, myopia is a very common eye disorder, and you'll be surprised to know that more than 50% of the population, especially the younger population, in the many industrialized countries right now are suffering from some degree of myopia. So it's a very common eye disorder, and there is a term called myopia epidemic, which most of the world is going through. Thanks to this COVID epidemic, many of the kids were restrained inside the house, and constant near work and lesser outdoor activities has added to this myopia epidemic, and we are facing a challenge of increased burden of the myopia. So what is this myopia? The light which passing through the cornea and the lens, it gets focused, it has to focus on the macula, that is the central part of the retina, where we have the best visual acuity. Now, if you compare this eye with a camera, so these cornea and the lens are like a front lenses of a camera. So when we focus for a different, the objects of different distance, we have to use the focusing knob, which focuses these two lenses. But ultimately, if the image has to be captured properly, then the negative or the camera's the reel has to be good to capture those images, which it receives the light and then sends the information to the brain. So overall, myopia is a condition where the light does not focus onto the retina, but in front of it. So what we do for correction with the simple glasses, what we prescribe, they actually bend the rays, help us to push the rays onto the normal retina or the macula. Coming to the classification, there are several ways to classify it. Axial, that is when the length of the eyeball increases and light falls in front of it, then it is called axial. Curvature, where the cornea is too much bent so that it bends the light too much, and that is curvature. Most important classification we need to remember is simple and pathological. So what is simple? Simple myopia does not lead to the other degenerations of the eye. It is just a mild variety of myopia wherein it is the dioptric power runs to few diopters, but it does not is not associated with excessive elongation of the eye or the degeneration of the other parts of the retina. Now, what are the risk factors? The race, ethnicity, gene, education, and lifestyle. So how does this play out? Now, when an infant is born, it is actually hyperopic, that is opposite of myopia. Now, there are certain factors like at birth, there can be some amount of infection or a premature birth or a trauma which might have happened immediately after the birth, which leads to oxygen deprivation, congenital cataract, ptosis, or any of these can lead to myopia. The other most important factor is the genetic. Say if none of the parents are myopic, then the chances of the kid having a high myopia is very less. Yes, they can still have a myopia of lesser degree, say -0.5 to -2. at the age of 8 to 14, and even between 20 to 25, it stabilizes at max -3, not in all the cases, but in majority of the cases. Whereas if we have a parent who is myopic and who has a high myopia, then if one parent is having high myopia, the risk is it is there. If both the parents are myopic, then the risk is much higher. So how does this translate? Between the age 5 to 8, there can be a mild to moderate myopia of -5 to -2. Again, I'm saying in majority of the cases, it is not unusual to see myopia of a higher degree, say -5, -8, even at this age. But most of the times, this myopia is diagnosed between 8 and 14. That is because the kids are picked up to having the myopia when the school screening, or they are intelligent enough to say that they are not able to see the things on the blackboard. By that time, myopia might have been more than -2 or -5. So by the age of 8, 2025, where the myopia reaches its maximum, beyond that, the changes are very less. We can have a myopia of -6 and higher. So the importance of this thing is, it is very crucial to see that the kids at our home are being screened for myopia at least once in a year, because myopia at the early stage may not have any symptoms, because the near objects may be clear for them. They'll have difficulty only in seeing distant objects. Now, coming to the symptoms. So what are the symptoms that we are going to see in a patient with myopia? A kid might sit too close to a TV screen or chalkboard. They may not be able to see very distant objects when we are able to see. So it's a good idea to hang a calendar at, say, 6 feet or beyond, and where we are able to see, and ask the kid, the child at our home, to close one eye and see if they can read, and then close other eye and see. Many times what happens is the one eye will be all right and the other eye will be having myopia. So with both eyes open, the children will be able to read that. So to check with one eye closed is a good idea thing. Excessive blinking, rubbing of their eyes. These are some of the symptoms which should alert the parents. At an older age, beyond say 12 or 14, the symptoms can be blurring of vision on focusing on distant objects, frequent squinting, frequent headaches, and trouble at the night travel. So these are some of the symptoms which should alert us that it can be myopia and you should seek a doctor's consultation. Coming to my main topic today, which is myopia and the other complication, that is other disorders. So myopia itself can be a risk factor for developing other eye disorders like the cataract, retinal detachment, glaucoma, and macular degeneration. So higher the myopia, higher the risk of developing these complications. Of this, the most important thing we need to see is the retinal detachment, which is 9 times more if the myopia is -3 or greater. If the myopia is -5 or greater, the risk becomes 21 times. Now, what are the complications that can happen because of myopia, and essentially a pathological myopia? Now, as the eye elongates because of the genetic predisposition or because of the environmental factors like lack of outdoor activities or constant near work, the eye starts elongating beyond its capacity. With that, we see that the corneal curvature can get affected and it can lead to astigmatism, where we treat it with the cylinder powers. The zonular weakness, zonules are these tiny slings which operate the lens. They help to hold the lens in position and to focus and refocus. Cataract, this lens can become opacified. Vitreous degeneration, the eye is filled with most of the eye, majority of the inside of the eye is filled with a jelly called vitreous, and that can undergo degeneration. Retinal degeneration, when the eye elongates further, this is the sclera and this is retina. So this retina can stretch beyond and it can undergo degeneration, which can in turn lead to retinal detachment, neovascularization, and staphyloma, which I'll be dealing with later. Coming to the functional disorders, with this, patients can suffer from subnormal visual acuity. Floaters. So what are these floaters? As I mentioned, at birth, eye is filled with vitreous, which is in the jelly form. So as the age increases, this jelly becomes liquefied. In cases of myopics, it is not just the aging, but it is the elongation of the eyeball, which can cause early liquefaction of the vitreous, and it can lead to floaters and flashes, which I'll explain in my next slide. Apart from this, there is something called neovascularization, that is choroidal neovascularization, which can happen in myopic patients where the abnormal blood vessels appear at the center of the retina and they bleed. So at that particular area, the patient may not be able to see anything. They'll see a black spot in the center part of which is called scotoma. Amblyopia is another important factor which has to be treated and picked early. It is nothing but a lazy eye where one eye has more power than the other eye. Now the brain, it neglects the eye which is sending the blur signals, and it will start supporting the eye which is sending the right signals. So picking this up before the age of 9 is very crucial. Otherwise, beyond 9 or 14 years of age, the wiring with the brain becomes final, and this amblyopia may not be able to, we may not be able to correct. The correction of amblyopia is in terms of patching, where we patch the normal eye and we force the child to see from the eye with a larger power. There can be other issues like impaired dock adaptation and contrast issues with retinal degenerations. Now, to most of the eye disorders or the problems which can happen because of the elongation of the eye and the vitreous is explained by this. As I mentioned, at birth, the eye is in the jelly form, and with age, it starts becoming liquefied, and at the same time, it starts separating from the retina. Now, what happens in myopia is there is a faster liquefaction and abnormal separation from the retina. This is because there is an excessive elongation of the eye, and the jelly and the liquefaction cannot cope up with the abnormal elongation, and then that can lead to many problems, like we have a vitreomacular traction where the jelly is liquefied, but it is very strongly adherent to the macula, which is the most important part of the eye. Then it causes vitreomacular traction. That means it is pulling on the retina. Then we have vitreopapillary traction, where it is pulling on the disc, optic disc. And we have an horseshoe tear and a retinal detachment, which is common in myopic patients, where the liquefied vitreous falls forward and causes traction on the retina, causing a break and leading to the retinal detachment. So this is how a vitreomacular traction appears. We can see here that this is the posterior hyaloid or a thick band of vitreous which is attached to the, this is a normal retinal OCT, optical coherence tomography, where we see a M-shaped thing. And here we see that the retina, which is, and we have the maximum visual acuity here. This is the most important part of the eye. And we see that this part is being affected by the abnormal liquefaction and attachment of the vitreous. So this is vitreomacular traction, and this is myopic retinoschisis. Chisis means there is separation of the layers of the retina. If it is not treated, the vitreomacular traction is not treated, the traction can again lead to the next step, which is macular hole, where we see that there is a full thickness defect. This is the retina, and there is a gap which appears because there is a tissue defect in this. This is called a macular hole. Now, the relatively more dreaded complication of myopia is a retinal detachment, where there is a break, or you see that there is a breach in the retina, and it starts detaching the retina from the underlying choroid and the RPE. Now you see this is an attached retina. This is how a normal retina appears. And this is a detached retina, where there is a break and the fluid or water content from the vitreous cavity goes inside this and separates this retina from the choroid. So this is a retinal detachment which can happen as a complication of myopia. Coming to the myopia and degeneration, myopic macular degeneration is again more common in industrialized and educated population, whereas it is slightly less in rural population because they have because of their lifestyle, they are more used to the outdoor activities. the common visual, they can cause a visual impairment in form of, so this is a normal retina. This is how it appears. And this is a myopic retina, which is a high myopic retina. You can see that a normal orange red shiny retina is here, whereas here you see that there is a tigeroid fundus or a tiger skin kind of appearance because of the stretching of the retina, degeneration and pigment accumulation. You see these yellow patches here. These are the advanced stages of myopic degeneration where the retinal layers again get more stretched, and this a severe form of atrophy ensues. And these are the patients who will have very, very less vision. And unfortunately, we don't have any treatment for this as of now. But only prevention, only treatment can be prevention, wherein we have to go for more of outdoor activities and stuff like that. Coming to the peripheral retinal degeneration. Now, whenever you go for an eye checkup with a retinal specialist and you have a myopia, this is what a retinal specialist looks for, because myopics are known to have these peripheral retinal degenerations. Namely, we can have an horseshoe tear, which I showed in a previous slide. Now, once we have this horseshoe tear, you may not have retinal detachment immediately, not in all the cases. Sometimes it can happen, but most of the times, these retinal degeneration like small holes or the atrophic holes or the tears, they appear, and after months or a year, they may cause detachment. So whenever you go for a regular eye checkup, the retinal specialist will examine your retina for such lesions, and there is a simple treatment, which is laser barrage treatment. We give a laser treatment around these breaks and make sure that this break does not cause retinal detachment. So it is important that any myopia patient should go and have their eye checkup with the retina specialist once in a year and follow the advice given by them, and do not neglect saying that you have a good vision and still the laser has been advised to you, because your vision will be affected only when the central part of the retina gets detached. Whereas these are the sinister signs, which are like a time bomb, which are sitting in the far corner of your eye, which you may not be able to identify and may not be having any symptoms. Coming to the management part. Now, what is more important is a good clinical examination to examine the eye from the posterior most part, from the cornea lens to the retina and every nook and corner of the eye, and come to a diagnosis and see what grade of myopia this patient has. And accordingly, we have to suggest the follow-up. If it is a simple myopia of less than -3 and there is no genetic predisposition or hereditary factor, then we can see the patient once in 2 or 3 years, or as and when required. Whereas if patient has any signs of pathological myopia or a family history of retinal detachment, or there are signs which needs to be followed up, then we may have to see the patient little frequently, like once in 6 months or in a year. So what are the investigations that a retinal specialist may perform on your eye? This is a B scan, that is ultrasound scan. Sometimes we do that to diagnose as choroidal detachment or retinal detachment. Fundus fluorescein angiography, where we inject dye and study how the dye is traveling inside the eye and leaking inside the eye, only in certain conditions, as I mentioned, in cases of choroidal neovascular membrane. And OCT and OCT angiography is again one of the important factors which are helpful in a routine management. As you can see, it's the myopic macular cases with posterolateral traction here. So coming to the treatment, so most common treatment that is followed is the prescription of glasses. As I mentioned, it is very important during the childhood to adhere to the strict glasses. Wearing the strict glasses, the child should be motivated and make sure that wears the glasses properly. Otherwise, the amblyopia or the lazy eye can set in. Outdoor activities is again one of the underrated and most important thing which can help in preventing the progression, rapid progression. If not, it may not completely stop, but it can prevent a rapid progression. And then coming to the surgery, so most of the complications which I mentioned will need a surgical correction for, like, vitreomacular traction, full thickness macular hole, myopic retinoschisis, and retinal detachment. So let us see some surgeries, what we do. So if once you come across a VMT, which I showed the picture where the vitreous is pulling on the retina or ERM, we do a surgery called vitrectomy. So what are the steps? You remove the jelly inside the eye and you identify these are the layers. This is the optic disc and this is the fovea or the macula, which is most important part of the eye. And you peel that abnormal vitreous which is causing pull over the macula. So certain dyes we use inside the eye to visualize the layers of the retina well. So this is an epiretinal membrane and this is an internal limiting membrane. So this surgery is performed in patients who have complain of metamorphopsia, or they say like that the center part of the eye is they're seeing that line is bent or it's not straight. Those can be symptoms, and this surgery prevents the complication of macular hole. Coming to the macular hole surgery, so here also the principle remains same. We remove all the vitreous, and this is the macular hole what you are seeing here. So again, the ILM is peeled, the interlimiting membrane, which is one of the outermost layer of the retina. So that will be causing the sideward traction on the hole. So the idea is to remove the traction and allow the hole to close. So what I'm doing is this surgery is inverse peel, which is we leave some amount of ILM into that hole so that it acts as a bridge and it acts like it pulls the both edges together like a glue. Otherwise, in the routine surgery, we just peel off that ILM completely and then we fill the eye with the gas. So once we put gas inside the eye, we may ask the patient to maintain prone position or the head down position for 2 to 3 days. So this is, we have put gas inside the eye now. Coming to the retinal detachment surgery, there are two types of surgeries which we do. This is a scleral buckling surgery, where the surgery is done from the outside of the eye. We don't go inside the eye. You can see that there is a retinal detachment here, and we are examining for the break, which I showed in one of the, so this is where the break is. This is the break. And once we have identified the break, we have to mark it on the outside part of the eye. And then we put a silicone band here. So this is the silicone band which pushes the eye wall towards the retina. Now, whatever fluid was there behind the retina is removed from the outside of the eye. So now you see the retina is already attached, which was already detached. See the height, from outside, the retina has been pushed. And wherever the retinal holes were there, we give a cryotherapy, which is nothing but a formation of the ice ball, which creates some kind of inflammation and scarring so that the retina, the holes close and the retina does not detach. So this is a silicone tire. Wherever the breaks are there, we give more push in that particular area and the retina gets attached. So this is a scleral buckling surgery. Coming to the vitrectomy, which is another way of treating the retinal detachment. Now, this is one young patient who had retinal detachment, but it was not picked up early. So he developed cataract also. So I had to remove the cataract. And you see, this is a retina which is detached. Again, we use certain dyes. In that case, it was a blue. In this case, we're using a triamcinolone crystals, which help us to identify the vitreous. So this is the jelly which I was talking about. So we have to remove this completely because this is the one which causes pull on the retina. See this, when I'm trying to pull this, it is pulling the retina with it. So carefully, we have to remove the jelly, separate it completely from the retina and go on peeling it completely and now attach the retina with the help of PFCL. This is another handy tool which we use. And once we have done that, we remove the fluid which is behind the retina and allow the retina to go back. So this is an endocautery to make sure that the edges of the retina does not bleed. And also after the fluid gas exchange, we should be able to see the retina well. So this PFCL acts as a third hand. It pushes the retina behind and all the fluid comes out through the break. This step is called fluid gas exchange, where the air goes inside this infusion cannula and using a flute needle or a large cylinder bore, we remove the fluid. And this is the laser treatment. In buckling surgery, we did cryo. Here we use a laser treatment for the margins of the break. And then we may put a tamponade cord, either silicone oil injection or silicone oil or C3F8 gas. So this is how it appears before and after surgery. See the hole before, and here it is closed near normal. This is a VMT before and after surgery. So these patients, they do very well and they maintain good vision for life. Myopic CNVM or a choroidal neovascular membrane. Here there is a bleeding and we give an injection called intravitreal anti-VEGF injection. And after the injection, the fluid disappears and the patients can again start seeing better. So to conclude, myopia is very common. Early detection and glasses prescription takes care of most of the cases. Regular follow-up is very important because it's just not the pathological myopia or a higher degree of myopia who have complications. Any myopic patient will have higher risk of developing retinal detachment or other complications compared to those who do not have. Pathological myopia needs a different strategy altogether because it is the disease can lead to many complications. These complications can be treated successfully provided we diagnose it early and timely intervention is done. Thank you all.